Welcome back to the Montana Minute Podcast. It's Zach Reamer here with a continuation on one of our series. Today we're talking about neonatal abstinence syndrome and other impacts that drug exposure in the womb can have on a fetus and the lingering effects after a child is born and goes off to school. For parts 1 and 2 of this series, be sure to go back and listen to my conversations with Dr. Bonnie Stevens at the Neonatal Intensive Care Unit at Community Hospital in Missoula, and Marshall Lambert from the Bureau of Indian Affairs. Today, I'm speaking with the pediatrician Dr. Thomas Strizich about his experience working with drug-impacted babies and their families. We talk about the different effects of different drugs, types of interventions for these children as they age, and the need for teamwork between care providers and other professionals who work with these children. Well, without further ado, let's just get into my conversation with Dr. Strizich. Give me kind of a brief overview of who you are and your background. I'm sitting here with Dr. Thomas Strizich in Helena, Montana. You're a pediatrician, and from what I saw in the Helena Independent, top pediatrician in Helena. So congratulations on that
Thank
accolade.
You.
Yeah, tell me a little bit about your background.
My wife is good about stuff in the ballot box, so
okay.
That's good. So I'm a general pediatrician. I've been practicing medicine, general pediatrics in Helena since 2000. My background is that I'm from Helena, born and raised here, and I went to school undergraduate at Gonzaga, where I got a degree in biology, and then I went to medical school, University of Washington School of Medicine, and then I completed my residency at Primary Children's Medical Center in Salt Lake City, Utah in 2000, and then I returned here to Helena to start practicing. I treat a wide variety of patients from sort of cradle through adolescence and off to college, managing newborns all the way through adolescence and young adults. And so my experience is in general pediatrics from newborns, premature babies, and on up.
So your breadth of treatment for children goes all the way up until they are off to college. You see 18-year-olds as well as infants and newborns.
Yeah, that's true. So it's kind of rewarding to be able to be there when a baby's born, and if they have a tough time to sort of get them through that, and then to do all their wellness visits and their sports exams and take care of everything, and then to be able to, wish them off to college. Occasionally they'll come back home and have a problem during college that we can manage. So it's rewarding to have that continuity of care from beginning to end.
And we're here to specifically kind of talk about neonatal abstinence syndrome, NAS. So in your kind of years of experience, how have you seen the number of babies coming in or the number of pregnant mothers coming in with a drug addiction change? Some of the reports that we can see have shown those numbers coming up. I'm wondering what it's like at a clinical level to see these increases.
Yeah, and so I work here at St. Peter's Hospital in Helena, and we have a newborn nursery as well as a special care nursery. And occasionally we'll need to manage a baby with neonatal abstinence syndrome in that special care nursery. And clearly, I think all the numbers show that there's been an increase in that abstinence syndrome, over the past 19 years that I've been practicing in Helena. There are 3 major areas where we've seen increases. One would be in the narcotics, so the opioid use, and certainly it's been all over the press and in the news about more lenient prescription writing from physicians for patients, and that's been all over the newspaper. So that's one area that we've seen. The second has to do with the methamphetamine crisis, and we've seen a fair amount of methamphetamine use amongst all the populations here in Helena.
Right.
Both the narcotic, the methamphetamine, and then finally, marijuana usage as well. So since that's become legalized in the state, although not federally yet, statewide, we've seen an increase in that as well. And neonatal abstinence mostly pertains to the narcotic use, although other drugs can cause an abstinence syndrome as well. Things like barbiturates and benzodiazepine, cocaine, amphetamines as well can cause that abstinence syndrome. But clearly in Helena, we are doing more referrals to Department of Family Services to come in and evaluate families. We're seeing more babies who have been adopted out or placed with foster families until they can sort out, is the mother going to be capable of raising this baby with an addiction or a drug problem?
Mm-hmm. And I imagine that's probably the best case scenario. Is the mother who carried the baby and gave birth should be in that baby's life if possible. We want to help them getting off of the drug and becoming the best mother they can be. I imagine they always want to be involved in their child's life, but we're seeing quite a lot of involvement from Child Protective Services and foster placements. That I'm sure that complicates neonatal abstinence syndrome and the developmental effects that it has on a child as they grow. Can you talk a little bit maybe about that, and how once a child has gotten over that initial withdrawal and grows and goes through school, what are some of the effects that we're seeing from kids as they grow and perhaps are in the foster system or not in the foster system?
Sure. And just to pivot back to what you said, make a comment about that. I think Family Services always tries to do reunification with the family as much as possible. It does get a little bit tricky and complicated because some of those babies can be affected, by the home environment and the parental drug abuse and their ability to parent, and children can be neglected. A lot of the spike we're seeing in Montana clearly has to do with methamphetamine, the DFS referrals. And so we do try to reunify as much as we can, but if there are relapses, it gets a little bit tricky in trying to make that judgment. Effects of children, it can start prenatally, it can start postnatally, and it can start as young adults as well. And so prenatally, the effect of drugs on the fetus can have a profound effect, especially during the first trimester of pregnancy. There can be dysmorphic features, there can be other effects in the way the baby develops. And then right after the baby is born, of course, the neonatal abstinence syndrome, those symptoms can be an issue. And then long term, depending on what medication, what drug was used or abused, there can be effects on children as they become older, toddlers in grade school. You can have effects on young children that would include cognitive impairment, so there can be difficulty with executive functioning, memory, ability to process. There can be behavior concerns, conduct disorder. There can be psychiatric concerns, things like attention deficit disorder, which is commonly described in a lot of drug use, maternal drug use, as these children get older. Again, conduct disorder, there can be depression, there can be anxiety, just a general host of behavior problems as these children grow up. And so clearly you need to identify this early and try to take proactive measures prenatally.
Those proactive measures, I'm sure, make a world of difference as well. And I'm thinking of maybe a foster family or even that parent who's been able to get off of their drug and become the best parent that they can be. It's going to be probably difficult raising this child as it is raising any child, but
Sure.
There comes some added concerns and considerations. What difference does good parenting make and having skills to help these children make for them and their development going forward?
Unfortunately, some of these effects are going to sort of be baked in the cake, and so that will come with the territory. And if the fetus has been exposed to those drugs, that is going to have an effect. But having a good foster parent or a biological parent who is proactive in making sure that the child gets the services they need. So if they do have difficulty with cognitive impairment or growth or development or attention deficit, that they're getting the necessary resources, whether it be speech therapy or counseling or special education services at school, have an individualized education plan in place, are all going to be important. And I think a parent or a foster parent, good education and making sure that they know what to look for and watch for and sort of be on high alert to monitor for some of these problems, I think will make a big difference. We see that in other realms too. Autism would be an example where, it's a difficult diagnosis and a tricky problem. But the earlier that you get services in place, speech therapy, occupational therapy, you can make a difference in the overall development and progression of these children long term.
Yeah, so what are some of those services? You've mentioned a few that you do referrals for families.
Sure. So it depends on, what symptoms would arise, but there's a organization called Family Outreach that is statewide and in Helena. So getting them plugged in with Family Outreach, they do a lot of good case management as well as surveillance for developmental milestones, and they can do referrals and make sure they get developmental assessment necessary. If there is a language impairment, you can refer to speech therapy. If there's any sensory integration difficulty, a sensory processing problem, you can refer them to an occupational therapist. If there are behavior concerns, then making sure that they get plugged in with a counselor or a therapist. If there's learning difficulty, which you can see, make sure that they are in tune with 504 plans and special education plans at school, and even some of the Sylvan learning centers to help them maximize, their overall development. And so all those things taken together can help the child.
It's a wide range of services. It sounds like there's quite a bit out there. Do parents struggle to find these things without a good connection to a pediatrician, or it sounds like once they're in the system, they've got referrals, but how often do you have parents coming who just kind of are lost and not sure where to start?
It's fairly common. It's kind of parent dependent. Some parents are extremely proactive and really curious and are on the internet and reading everything they can and making sure they get all the services. Other parents are not as proactive. And so it's kind of parent dependent, but if they have a good primary care physician or provider that can do the evaluation, assessment, look for red flags, and get them plugged in with all the services, that's certainly important.
Maybe we could go back a little bit and talk kind of about the symptoms, just really briefly. Sure. What symptoms you might see starting really early, and then maybe a little later on as children go into the school age.
Sure. And so we would be alerted to a baby who's at risk for neonatal abstinence by the history, the prenatal history, the pregnancy history. And so that could be history of drug use. There's other withdrawal syndromes that can be associated with other medications as well. So moms who might be on an antidepressant medication like Paxil or Prozac, they can have withdrawal symptoms from that. So it's not exclusive just to, a drug use, illegal drug use, or narcotic use. So some of those symptoms include, the central nervous system. So those babies might have a high-pitched cry. They might be really irritable, have an exaggerated moral response, which is kind of a startle response. They might have difficulty with self-regulation. They may have some temperature instability. There's a whole scoring system that we use called the Finnegan scoring system. GI symptoms would include things like poor feeding, some vomiting, perhaps some diarrhea. Some of those babies will yawn a lot, they'll sneeze a lot, excessively irritable, sweating. So a whole host of symptoms that we monitor. And so if we're worried about a baby, we'll institute sort of a Finnegan scoring system, and the nurse will monitor for those symptoms over time every 4 hours. And if they reach a certain threshold, then we'll try to institute measures to sort of address some of that withdrawal.
And how about as a child ages? And I know you've mentioned ADHD might begin to come to a head in school, especially, I'm sure. Right,
yeah. And so it'll be the typical things I mentioned. So a parent may worry about a child's behavior, they have a difficult temperament, hard to stay on task, have a hard time self-regulating, might have some hyperactivity, some inattentive symptoms, some poor focus, other behavior concerns. And then usually the educational problems oftentimes may come up in preschool or kindergarten, where a child might be falling behind, and hopefully there'll be a proactive teacher who will be alert to that, get the child tested, and kind of get them plugged into the special services at school.
Is there a difference between drugs as well? What type of drug the baby was exposed to in utero? Between, say, a more addictive stuff, I don't know. I'm not a clinician, so I don't want to make a more addictive type statement, but I'm thinking about like opioids versus methamphetamines versus depression medication, like you mentioned, that can still have some effects.
There's definitely a difference. So the classic neonatal abstinence syndrome really was described with opioid addiction and withdrawal. But we've learned since that time that other medicines can have withdrawal symptoms as well. So barbiturates, benzodiazepine, cocaine can do that as well, and some amphetamines. Marijuana doesn't tend to have as much of the withdrawal symptoms. Methamphetamine doesn't tend to have the withdrawal symptoms that you see with narcotic. But long term, then you can see other effects with the marijuana use or the methamphetamine use related to cognition, behavior, development, ADHD, conduct disorder, those type of symptoms.
And what about nicotine, cigarette smoke, maybe even secondhand smoke? Maybe we're kind of venturing into a different type of
Sure.
health
So
issue.
nicotine is the most used legal drug during pregnancy, and then number 2 would be alcohol. And nicotine can have some immediate withdrawal symptoms too, with some jitteriness, some irritability, some rapid breathing. Don't see that often, but we do see that occasionally. Alcohol, of course, it's well described that prenatal early exposure to alcohol use can lead to a syndrome in children called fetal alcohol syndrome, which is described by some cognitive difficulties, definitely some attention deficit disorder, some distinguishable features on the child. They kind of have a thin upper lip. They have kind of a flat spot right above the lip called the philtrum. They can have microcephaly, tend to have a smaller brain. So alcohol is certainly described prenatally as well.
That's a really specific syndrome. Compared to
the
neonatal
others.
abstinence syndrome, others. Okay.
Mm-hmm.
How about, I just want to ask a little bit about what you think your role is in helping to prevent some of these issues and concerns. And maybe it's hard from your perspective because you don't see a parent until they know they're pregnant and could possibly have been using the substance for a while before the time that they come in, or maybe not at all. Maybe the first time that they're plugged into the system is when they go to the hospital to give birth. What do you think? What do you say your role is in all of this and helping to prevent some of the increase that we're seeing?
Yeah. So if it's a first-time mom, I may be behind the 8 ball, and it's really the obstetrician and the family practitioner who will be on the forefront to make sure that the mom is getting all the prenatal care, to do counseling about any addiction, get them plugged into services early on during the pregnancy. If it's a mom that I've known well and she has other children, then certainly if I have suspicion or concern, then I can start counseling her and making sure, that she's plugged into resources. So, we can sort of intervene at an earlier time. But oftentimes I'm a little bit late to the party. It usually happens, earlier, and I go to the delivery and I learn about what had happened, prenatally, and then I'm watching for symptoms and getting services involved. And then, of course, after the baby's born, just monitoring for potential early stream and then downstream effects of the side effects of these drug exposures.
Would you define early stream versus downstream, maybe even just for my benefit?
Sure. So in the immediate postnatal period, we'll be monitoring the baby, for several days after the baby's born. And then as the child is raised and grows up into an infant, a toddler, a school-age child, we're monitoring for any potential developmental behavior, cognitive impairment.
Maybe a question I can ask is the magic wand question. If you had a magic wand and could solve one thing and that's no longer a concern at all, what would you change? What would the magic wand wave be?
That's a tough one. We're human and we all are prone. We are genetically and environmentally tempted and prone to addiction on any number of levels, and whether that be drugs or any number of things. And so, that's a tough one. So,
rewriting genetics.
Rewriting genetics is hard. So, some of these addictions, alcohol and drugs and nicotine, all those can be wired genetically. Clearly, alcoholism, there tends to be strong family history for alcohol usage through generations. And so that's a difficult thing to do. But clearly public education about, alcohol addiction and usage, drug addiction and usage, earlier educational interventions, more public awareness of that, and making sure that people are aware of, clearly the side effects of drugs. I think people are pretty well aware. I think the opioid crisis clearly has people on the edge of their seat and paying attention, and law enforcement and courts, and people are really honing in on that pretty good. But a lot of what I do as a pediatrician is preventative care, and the more prevention education that you can do, the better the mom and the baby.
that helps to bring down a little bit of the stigma and the shame that surrounds it as well. It's just being educated and helping the clients and your patients to understand.
Absolutely. Yeah, there's stigma with addiction, certainly mental illness. Oftentimes that goes hand in hand. Some people will self-medicate with alcohol, marijuana, other drugs to treat or take care of a psychiatric illness or a problem they're having in their life.
So if I missed something, what's the one thing you think that one question I didn't ask that I should have, thinking that this will be heard by parents and people working in the field of, child protection or law enforcement or foster care? What do you think people should know that I haven't asked yet? Or did I ask all the perfect questions?
You're too good. You've asked all the great questions. It's clearly, addiction is a complicated problem, and identifying it and treating it and getting resources involved is really going to be important. And then making sure that, monitoring children for any side effects and, helping these parents as much as you can, if they can become good parents, If not, and there's been several relapses, then, you got to do what's best for the child in that scenario too.
Right. I'm sure you see both sides where this is a chronic issue. 2, 3 children have been affected all kind of by the same behavior. Do you see the other side often where this is a turning point and an opportunity for a parent to kind of turn?
Yeah, that's very nice to see that. Occasionally I do see that. I've seen, sort of generational methamphetamine addiction and usage. Recently had a family. But then you see people who struggle with addiction, who are plugged into services, and they're able to overcome it and move beyond it and, do the best they can for the child. But it's always a tricky dance and a tricky balance for those families. Prenatal drug exposure to the infant and the fetus is a definite problem. It can certainly affect their growth. It can affect their development early on. You can have withdrawal symptoms and long-term stuff. And so, parents need to think really careful, especially an expecting mom or young mom who's thinking about having a baby, to really do the best they can, take care of the body, avoid things that can certainly affect the fetus, especially early on, because that's where a lot of the organs of the body are being formed. So if exposed early on, then you can really affect that in a profound way. There's long-term effects too if they're exposed later, but early on can be a real problem. So just being really smart about your health, and especially thinking about becoming pregnant.
Yeah, that's those foundational kind of moments in a child's development.
Yeah.
I just thought of one other thing as well.
Yeah.
And it kind of revolves around how neonatal abstinence syndrome is really modeled on the withdrawal from opioids. What limitations do we have there? Because in Montana, opioids are definitely a problem. But we maybe see more people coming in with methamphetamine use or addiction or other types of drugs and alcohol. Alcohol may be off the table because we have a really well-described model for that. But what limitations do we have from this kind of base of literature coming from opioid withdrawal?
Well, fortunately, some of the symptoms that other drugs can cause are similar to narcotics. So you can use that Finnegan scoring system, to monitor for other withdrawals. Some of the symptoms with non-illicit drug withdrawal, such as an antidepressant, an SSRI, Prozac, or Paxil, can cause some of those symptoms too. Barbiturates can cause that. Benzodiazepine addiction can cause that. Cocaine. So you can use some of those scoring systems for that. And commonly, some of these moms have, polydrug abuse. So they're using multiple drugs. So you got to be watching for all that. Fortunately, methamphetamine and marijuana doesn't appear to have the same kind of withdrawal symptoms as some of those other drugs do.
So you can see kind of those differences. And a benefit of being a pediatrician is you can follow that child up until the age of 18, going off to college. So maybe some of the referrals don't change, but when and how to apply them, you can help kind of advise during that whole process.
Absolutely, yeah.
Yeah, that seems like one of the big pieces, bringing all these different players together. You've got education, you've got mental health, you've got medical, and having a united voice. Yeah,
it's a team approach. I'm just one person provider in the overall scheme of things, but it involves parents, it involves teachers, it involves physicians, it involves therapists, it involves grandparents, it involves everybody all the way up.
Absolutely. Okay,
Yeah.
well, I think that's it. And I really appreciate you sitting down with me and taking the time to chat.
You're welcome, Zach. Thank you.
Well, thanks again, Dr. Strizich, for speaking with me. I think the pediatrician's perspective is such a valuable one because they often work with children from birth to adulthood. And that is the kind of long-term observation we need to really understand the impact drug exposure can have on a child in utero. Well, I want to wrap up by saying thanks again for joining us. Be sure to visit our website at health.umt.edu/CCFWD. We recently added a bunch of new content to the website, including an amazing data tool that helps to visualize statistics about children and families in our state, including indicators on poverty, health, and many, many other measures. As always, we have training tools and other useful resources on the website as well, so just be sure to check it out. That's health.umt.edu/CCFWD. I'll have a link in the description. Until next time, take care of yourselves, and thank you for making a positive impact in children's lives. Bye for now.